A few in the lobby. All right. So here we are. Welcome everybody to our final webinar of Hypopara Month. We're so excited that you're all here to join us, and we know there'll be some of you online a little bit later. But today is a very exciting day. We have with us some of our friends from amolyt, and they are going to do an update on the phase 3 Calypso study. And I'm going to go ahead and turn it over really quickly to them. We have speaking today, we have Michelle Ovies, who is the Senior Medical Director at amolyt. And then we have Gail Shaish. I'm going to mess up that last name, I know, but she will introduce herself, Miss Gail, and she's the Associate Director of Clinical Project there at amolyt. So we're very excited to have you guys here. Thank you so much, and take it away.
Hi, everybody. Thank you very much, Patty, for the introduction. Very happy to be here with you. My name is Michel Ovies. I'm Senior Medical Director at amolyt. And our presentation today will be divided in two parts. I will start with the mechanism of action and remembering the result from the phase 2 study. And then Gaël Charrier will continue and present to you the protocol of the upcoming phase 3 study. Please interrupt me anytime you want for any question. I will be very happy to answer all your questions. Next slide, please. So we're going to talk today about our product, which name is eneboparatide. You previously named AZP3601. It's a peptide. A peptide is a small protein. And the mechanism of action is summarized in this figure. As you can see, eneboparatide has a specific property, which is to bind to what we call the R0 conformation of the PTH parathormone receptor. The usual conformation of the PTH receptor is the RG conformation, while our product binds to and activates the R0 conformation of this receptor. Next slide. And because of this specific properties, this gives to our product particular properties. As you can see, we have three figures here. And we have tested initially in animal models, but here in human volunteers, normal volunteers, what we call the pharmacokinetics and the pharmacodynamics of our products. In other words, if you look at the figure on the left, you can see that one important properties of this compound is to have what we call a short PK. Meaning that whatever the dose of product we administer to a subject or a patient, this product has a very short half-life, meaning that it stays for less than 2 hours into your blood. But surprisingly, in contrast to this very short half-life, it has a very prolonged a duration of action on what is important for you, which is serum calcium. In other words, it stayed very short in the blood, but has a very prolonged effect on serum calcium, obviously increasing serum calcium, as you can expect. And you can see in the figure in the middle that according to the dose, you have a prolonged effect up to 24 hours after a single administration of eneboparatide. And on the right part of the panel, you can see that in a second part of our initial study, we administer the drug for 14 consecutive days at different doses in different cohort of patients. And what is important to see here is that there is what we call a dose response to the administration of eneboparatide. And what you can easily see, even though you are not an expert, is that it takes 2 to 3 days. If you start at 1 on the left, you see that at 3 days after the initial administration, you reach sort of a plateau of effect on serum calcium that lasts up to the point when you stop the treatment at day 14, and then it goes down back to near baseline value. And this is very important, a very rapid effect, 2 to 3 days to reach the plateau. And the plateau is the higher the dose, the higher the plateau. And it takes 2 to 3 days to come back to near baseline value, which is very important for you patient, because the drug is active rapidly. And when you stop the treatment, the effect of the drug also goes down very rapidly. So to summarize, short half-life, meaning short stay in the blood, prolonged duration of action up to 24 hours after a single injection, and a very stable serum calcium, whatever the dose, when you inject the drug for 2 weeks consecutively. Next. Now, based on that, we have tried this drug in 2 cohorts of hypopara patients. And obviously, the first important aspect was of safety. And you can see here that eneboparatide was well tolerated. There has been no serious adverse event. And there has been some adverse event, which all were of mild or moderate intensity. And we have given in this table a few examples. Some patients had injection site reaction, usually erythema, and some patients displayed hypocalcemia or hypocalcemia episodes. You can see that in cohort 2, we had 9 episodes of hypocalcemia, and this was due to the fact that in cohort 2, we started at a very low dose of eneboparatide, which can explain the episodes of hypocalcemia in some patients. But overall, a very well-tolerated drug. Next. Now, what about the result? As you know, when we start the treatment with eneboparatide, we have to remove conventional therapy, active vitamin D, and oral calcium supplementation. In our study, patients were taking calcitriol or alpha-calcidol, and they were authorized to continue up to 500 milligrams per day of oral calcium intake throughout the 3 months treatment period. And you can see that in cohort 1, 10 patients, and in cohort 2, after only 2 weeks, most of the patients were off calcitriol or alpha-calcidol, and that most of the patients took less than 500 milligrams per day of oral calcium, and this was maintained after 3 months of treatment with eneboparatide. So most of the patients were off conventional therapy at the end of the 3 months treatment period. Next. Of course, what is important when you switch from conventional therapy to eneboparatide is to maintain serum calcium at a certain level. In that protocol, we aimed at maintaining serum calcium into a target range, which, as you know, because this is your daily practice, was quite, I would say, low, between 7.8 and 9 milligrams per deciliter. And you can see on the left for cohort 1 and on the right for cohort 2 that on average, the objective was obtained because the mean albumin-adjusted serum calcium was within the target range, both in cohort 1 and in cohort 2. I must say that in cohort 1, we had a few patients, 3 patients, that were slightly below the lower limit of this target range, which was slightly improved in cohort 2, simply because the titration of the drug, eneboparatide, was more important in cohort 2. At the end of cohort 1, the average intake was of eneboparatide 28 micrograms per day for a starting dose of 20 micrograms, while in cohort 2, we started at 10 and we ended up at 45 micrograms per day of eneboparatide. Next. Okay, serum phosphorus, I think we miss, okay, serum phosphorus was decreased both in cohort 1 and in cohort 2. As you can see, we have a similar profile in the two cohorts. Very early, day 1, after the onset of eneboparatide treatment, you can see that serum phosphorus decreases and remains decreased all through the 3 months treatment period, both for cohort 1 and for cohort 2. Next. What about an important parameter, which is 24 urinary calcium excretion? You know that urinary excretion of calcium is a very important parameter for the treatment of hypoparathyroid patients. It's a prognosis factor, and in that trial, you can see that at baseline, under conventional therapy, in cohort 1 on the left and in cohort 2 on the right, the average was above the upper limit of normal for male and female patients, and that as soon as day 14, 2 weeks after the onset of treatment, on average, we were already below the upper limit of normal, and the decrease kept going on, and at the end of the 3 months treatment period, we were well below the upper limit of the female and male patient range. Next, what is even more important is what happens in patients that had hypercalciuria at baseline. We had 7 patients out of 10 in cohort 1 on the left, and 7 patients out of 14 on the right. And you can see these are individual values that all patients in cohort 1 were fully normalized after 3 months of treatment in cohort 1, and all but 1 patient in cohort 2 were fully normalized after 3 months of treatment with eneboparatide. So we have a strong effect on urinary excretion of calcium, which is, as you know, an important aspect of prevention of kidney disease, chronic kidney disease, nephrocalcinosis, nephrolithiasis, and it is very important for you that a drug to treat your disease can reduce urinary excretion of calcium. Next. What about the effect on bone, which is obviously the second important target organ for treatment with eneboparatide? You have on the top for cohort 1 and cohort 2 the CTX value. CTX is a biomarker that can be measured in the blood and that gives information on what we call the resorption of bone. And at the bottom, you have P1 and P values, which depict the other aspect of bone turnover, which is bone formation. And what you see here is that during the 3 months treatment period, you have in this example a moderate, progressive, and balanced resumption of bone turnover. CTX and P1 and P increase in a similar way over time during the 3 months treatment period, and always well within the normal range of values, meaning that eneboparatide is able to resume bone turnover, but in a slow, progressive, and balanced way. In other words, this is very important because, as you know, this disease is mainly affecting women patients, and most of them are postmenopausal women. And if this happens tomorrow, this treatment is for life, and you want to protect the bone of patients that have tendency to display or to develop osteoporosis. So at some point, it is very important to have a drug that protects the bone, or at least is not harmful to your bone. Next. I will hand over to Gael, which following this phase 2 study data, will present to you the phase 3 study protocol. Gael, it's your turn.
Thank you very much, Michel, and I'm Gaëlle Charrier. I'm responsible for this phase 3 study from the operational side at amolyt Pharma, and it's my pleasure to present you this study that is just starting now in the US and Canada at the moment. So we call this phase 3 study the Calypso study. It's a phase 3, it's a global study, so what we call multi-center. There is going to be a lot of hospitals which are involved in this study. It is randomized and placebo-controlled. That means that at least initially in this study, we are going to compare patients which receive the active drug, eneboparatide, to patients that will receive placebo. And no one will know. This is double blind. And the objectives of this study is to evaluate the efficacy and the safety of the drug eneboparatide in patients with chronic hypoparathyroidism. So the design of this study is shown on this slide. There are 3 phases in this study. In the first phase, which we call screening optimization period, and which can last up to 8 weeks, the goal will be to ensure that all patients are optimized so that their serum calcium is for every patient in an optimization range. So the goal will be to optimize your conventional therapy to achieve this range. Then patients will be randomized. So it means they will be assigned to either the active drug eneboparatide or placebo. And there will be 2 chances out of 3 to get the active drug and 1 chance out of 3 to get placebo. That's what we call double blind phase or main treatment period. So no one will know which product the patient receive. And at the end of this period of 24 weeks, we are going to do what we call the primary efficacy analysis. So we will compare the efficacy of the drug versus placebo after this first 24 weeks. Then all patients will enter the open label extension period, which will last 28 weeks. All patients will receive the active drug, eneboparatide, for 28 weeks. And then under a separate protocol, if patients have completed this first year of study, they will be able to move to a separate study, which will be an open label extension, so another long-term extension study where all patients will also receive eneboparatide for at least 2 years. So what do we do in this primary analysis? We are going to assess the proportion of patients which have their albumin-adjusted serum calcium within their normal range and with independence from supplements. Then as Michel mentioned, we believe our drug has a strong effect also on urinary calcium, and in particular in patients with hypercalciuria. So that's what we are also going to evaluate as a key secondary endpoint. So if patients with hypercalciuria at baseline are normalized after 24 weeks of treatment. What is very important as well is patient symptoms and quality of life. So we are going to assess this aspect via questionnaires, so patient-reported outcomes. So during the study, the patients will complete some questionnaires about their symptoms, how hypoparathyroidism affect their life, their quality of life, their relationships, their sleep, etc. That's also very important to us, and that's also a key secondary endpoint. And of course, we will also assess safety of the drug via different evaluations. So we are going to look at bone safety, looking at these biomarkers Michel just presented, looking at bone mineral density, and some scores also about looking at quality of bones using different imaging methods. We will also assess the pharmacokinetic profile of the drug in the blood of patients and if patients are developing anti-drug antibodies, and of course, if there are any adverse effects, any abnormality on labs, etc. This study will enroll 165 patients that will receive the treatment. And to be able to show this secondary endpoint on hypercalciuria, we intend to have a minimum of 75 patients with hypercalciuria at baseline. And in addition to characterize the population, we will stratify the study based on etiology of the disease, whether patients have hypoparathyroidism because of a surgery or not because of surgery. Who can join the Calypso study? So it's a very short list of criteria. Actually, the list is very long, but making it very short. Any adult below 80 years old may participate. Patients need to have been diagnosed with chronic hypoparathyroidism for at least 1 year. The drug I will show you on the next slide is a self-injection pen. So patients have to be able to give injections by themselves every day, or someone in their home would be able to give these injections. And there are other criteria that will apply, and doctors will check that. So the product itself, it's presented into a pen for subcutaneous injection in the abdomen. So as I mentioned before, it will be self-injection or biodesigning. The injections will be daily in the morning, approximately at the same time every day. And we have developed 2 different types of pens depending on the dose that will be administered. So there will be a pen that administers doses from 10 to 50 microgram, and a pen which delivers doses from 50 to 100 micrograms. It's pretty easy pen. You just dial the dose on this window here and inject, and the needle is extremely tiny, so it's painless. Where does the study take place? So it's, as I mentioned, it's a global study. There will be sites in North America and in Europe, overall in 13 countries, and we are planning to activate up to 55 sites. And I'm sure you're more interested into the distribution into North America. So we have selected 3 sites in Canada. There are the orange dots on this map, and 14 sites in US, so the purple dots. And we are currently looking for additional sites more in the south of the United States. So this is the list of sites that will be participating in US and Canada, with on the right side the current status. So as of today, we are very happy to have 2 sites that are already open for recruitment, one in Washington State and one in North Carolina. And we are very close to open additional sites in the US and Canada. So these first 6 sites are very close to be opened. And then we are working actively to open the other sites shortly in coming weeks or months. We have developed a website that you can find on the www.calypsostudy.com, which will be launched very shortly, I think within three weeks probably, and which will provide additional information about the study medication. If patients have never participated into clinical research, there will be information about what is a clinical study, and as soon as we have sites that are activated, it will be possible also to see which study clinic locations are open for recruitment. So initially there will be not many, as you've seen, but it will grow over time. And you may be contacted, I mean, you can contact the site via this website. And I think that was my last slide, and then I believe we are going to take questions now.
Yes, we're going to open up the chat for questions. If anybody wants to add some questions in there, that's great. I will go ahead and kick us off for you while we wait for some questions to happen in there. Can you go back and talk a little bit about what it means to optimize, potentially what the details are for a patient? What does that mean, and when you're initially signing them on?
I answer, Michelle, or you want to
reply? Yes, go ahead.
Yeah.
Yeah.
So what we call optimization is to bring the serum calcium of the patients within a certain range, so that everyone is going, all the patients, when they reach this randomization time, they will all be in a similar range, so that we can assess the efficacy of the drug starting from the same point.
Gotcha.
So that will be optimizing the conventional therapy, so the oral calcium and the active vitamin D, so that everyone is in a similar range at the beginning of the study.
Yeah,
Okay.
basically the range is 7.8 to 9 milligram per deciliter for albumin-adjusted serum calcium. And on top of that, as Gail said, magnesium and 25 OH vitamin D levels.
Okay, very good. So would it be safe to say if somebody comes in below that or above that, then you work with them to make sure they're optimized before they get started? Is that our layman's terms from a patient perspective?
Yeah, that's correct. I mean, well, I suspect most of the patient would be rather below than above this range. But it's just an adjustment of the conventional therapy to bring them into this range. This is why, because we want all the study population to be sort of comparable and have baseline characteristics that are similar, so that the trial is reliable and everybody's comparable in terms of evolution under the study treatment.
Perfect.
But yes, if the patient is, for example, having 7.5 milligram per deciliter of albumin-adjusted serum calcium, so the investigator, together with the patient, will have to slightly adapt both active vitamin D and oral calcium intake so that the patient comes above 7.8, for example.
Gotcha. Okay, thank you.
So it can take up to 8 weeks.
Okay, very good. And then Kim asked, when can we expect trials for pediatric population?
Well, this is a good question and a very important one because, as you know, a lot of patients are children that have either genetic origins or other disease, mainly genetic origins. And this is a very important population, of course, and the fact is that they have specific characteristic for this disease, which means that sometimes diagnosis takes long years before they can be diagnosed as hypopara patient. The treatment is difficult, as you know, and they have a duration of the disease, which by definition is much longer when they come to the adult, as adult, when compared to the usual post-surgery hypopara etiology. So we are very well aware that this is a real need, but of course we have to first go to the Calypso study, demonstrate that our drug is efficient, and how much is it efficient to start the pediatric study. So it's going to take hopefully a couple of years or slightly more before we can envisage a pediatric plan or start a pediatric study.
Very good, thank you. All right, and then Miranda writes, thank you so much for sharing so much information. She's currently doing the optimization phase at Spokane site, wondering about the anti-drug antibodies. If you develop these, does this mean you have to stop the drug?
Well, this is a good question. You know, any drug that is developed, especially in this area of ETH agonists, or generally speaking, PTH drugs, all drugs have ADAs, anti-drug antibodies development. The question is whether these antibodies are really affecting the efficacy of the drug, and this is not always the case, obviously, and hopefully. And we will follow that carefully, but in terms of clinical practice and this study protocol, in any case, the investigator and the patient will have to adjust albumin-adjusted serum calcium, I would say, without knowing whether the patient is developing anti-drug antibodies. And on top of that, we have no evidence so far, no strong evidence that development of anti-drug antibodies are affecting the efficacy of our drug. So this phase 3 study will tell us whether this is the case, but so far we are pretty confident on this aspect.
Okay. Let's see. What is the opening time lag between Boston and, I'm sorry, I just lost it. It's in the chat there. So so you currently have Spokane and Greenville open. You have 165 patients that will join. What would be kind of the lag time in between? What if there's 165 in Washington? How does that work? There's probably not, I'm sure, but how does that work for a patient perspective?
I can take that one. So we are planning to randomize 165 patients across 55 sites in the world. It's not only these sites that you have on this slide now in North America. There will be not 165 patients by these two sites. It's going to take several months. So we think we are going to finish enrollment by or screening of patients by the end of this year or early next year. So there is some time to be enrolled in the study.
Just if I may add something, this is the largest study ever made in hypoparathyroidism. So 165 patients seems to be a small population, but it's a very large population for hypoparathyroidism. And I am quite confident that there will be some time, especially for patients in the US, to be involved over time. So be confident and be prepared.
Okay. And then Liz also said, could a patient start in Boston but transfer to Chicago?
It's a possibility. It's not easy operationally to manage, but if for any reason the patient moves and there is a site open in the other city, we may discuss how it can be transferred. It's better to plan that ahead. It's not usual, I must say, but it's possible.
Okay, very good. And then Liz asked, who and where will the placebo be mixed up if they end up in this group?
What do you mean with mixed up? Sorry.
Yes.
So maybe I can explain a little bit again about this double-blind phase. So at this stage, what we call randomization stage, there will be a system, an informatic system that is going to say, okay, patient X is going to receive this product, number X. So no one will know whether it's active or placebo. So during the study, you will not know. So that's the electronic, it's like a, it's by chance, it's going to be the system that says this patient. The investigator will not know, we will not know, so no one knows, the patient doesn't know. And then at the end of this period, everyone is going to get the active drug. So 1/3 of the patient, indeed, out of these 165 patients will receive the placebo. They will not know. That's not, we don't decide. So it's really based on chance. They will take 1 out of 3 that get placebo. And that's it. And then everyone gets the active after 24 weeks.
Yeah, I think this is very important. I understand that for patients, it's a real question to say, okay, I may receive only the placebo patient for 6 months. So why should I go into that study because it's a challenge, but at the end of it, the placebo treatment, being in the placebo arm of the study for 6 months, means nothing else that you will basically continue to receive your conventional therapy for 6 months. And at the end of it, as Gail said, you will enter the open label extension phase, where all patients, including of course those that were into the placebo group, will receive the active form of eneboparatide for at least 2 years. So I understand that 6 months is difficult. It's no luck if you are in the placebo group, but you have to be patient. At the end of the 6 months, you will go into the active drug treatments for at least 2 additional years, or even more than that.
Yeah, I think I got a little bit of clarification. She was wondering if you're on placebo, what happens? You go back onto standard of care.
Yeah,
Yeah,
that's a very good question. As
yeah,
Gail said, it is very important to understand that there is the sponsor and the investigator are making everything to make a clear trial. That is, we are not willing, the investigator or the patient, to know whether they're under placebo or active form, because this is a straightforward study. But at the end of the day, a patient that will be randomized to receive the placebo form of the study treatment, there will be an attempt to reduce the conventional therapy, which is intake of active vitamin D and oral calcium, for a few days or a few weeks. But there is everything that is envisaged into the study to, of course, prevent any safety problems, to prevent basically hypocalcemia. And the patient and the investigator will have any possibility to adapt or to come back to the initial conventional therapy in a stepwise manner to prevent any side effect or adverse event. So that in terms of safety, everything is made for the patient to be randomized into the placebo group to prevent any side effect or any adverse event. So no worries, safety is the first objective of that study. And even if a patient is into the placebo group, there won't be any problem. We have done anything necessary to prevent that.
gotcha. Okay, very good. And then why did small sites like Spokane and Greenville open up before larger markets such as Boston, Chicago, and New York?
Yeah, it's a good question. That's how the clinical research is working. Some of the sites are working with what we call central IRBs. So there are these institutions that are allowing us to do studies. So there is the FDA that gives the authorization, but also some what we call also ethics committee. So there are really, and some sites in the US are affiliated with this central IRB that are very fast. And that's why this, I don't know if we can say small sites, but this area that maybe are less known than Boston, or Chicago are open first. It's because their institute is affiliated with those central IRBs. So that's going very fast for those sites.
Okay, very good. Let's see. Somebody had said if they end up on placebo group, they would like their calcium and vitamin D mixed to maintain the calcium around 9.0 using, I think it's supposed to be calcitrol. Is this an option?
Yeah, this is a good question. Everything is made in this protocol to basically we'll not talk about whether a patient is supposed to be under placebo or supposed to be under the active form of the treatment, but we'll think about whether the patient is able to get rid of active vitamin D and oral calcium supplementation or not. If the patient, for some reason, while he's under the study treatment of eneboparatide, it is impossible to remove active vitamin D and to completely remove oral calcium supplementation, then the objective will be obviously to maintain albumin-adjusted serum calcium into the usual, I would say, range, which is 7.8 to 9 milligram per deciliter, as recommended by international guidelines. If the patient reacts to the study treatment so that he or she is able to get rid of active vitamin D and oral calcium supplementation, then the objective will be to bring albumin-adjusted serum calcium to 9 or slightly above 9 milligram per deciliter, because this will be an indication that since he or she no longer needs active vitamin D and oral calcium supplementation, then albumin-adjusted serum calcium can be slightly increased with respect to the usual range of value. So this is the way we have designed the study protocol and the guidelines for the investigators.
Okay. Then I had a question from somebody that said, if the medication stays in the blood for only 30 minutes, how does the calcium stay stable for 24 hours?
That's an excellent question. That's that's all about the mechanism of action and the specificity of our drug. This drug is very different from all the other drug either on the market or in development. It stays very short into the blood, but once the drug has bound to the receptor of PTH, it goes into the cell, and it certainly disappears from the blood, but it keeps being very active into the cell for up to 24 hours, and it is protecting and acting within the cells and not within the blood. So it's a bit strange when compared to the other drug in development or on the market, but stays short in the blood, but stays long into the cells and act to maintain serum calcium by its action into the cells.
Okay. And then, so from a hypopara community, we're kind of used to like 1 to 34, 1 to 84. Now we're coming out with this. What is the differences in all of that with your drug?
Oh, good question. I'll try to make the answer short and easy. 184 is the usual, I would say, complete form of the PTH. 134 is part of this full, complete form of the PTH. And our drug is another sort of cut of the initial form of this protein, and it's 1 to 36 amino acids. Amino acids are small pieces of that together build what we call a peptide, or we can call a small protein. And initially, people at MGH have slightly modified the small pieces of this small protein to give these specific properties, which gives a short duration in the blood and a prolonged duration of action in the cells. So it's these drugs are coming from the sort of the mother PTH form, which is PTH 184, and be it 134, 1 to 34 or 1 to 36 are our drug. They are modified form of the initial mother drugs, and with different properties and modification that have been brought to our compound, have given this drug specific properties which I've described before: short half-life and prolonged duration of effect of action.
Very good.
And if I may add, I don't know if it was the key difference, or we hope actually, that's what we want to demonstrate also with this study, is that the effect on the kidney and the bone will be different because of these properties of our drug.
Okay. And speaking of that, you had mentioned previously about osteoporosis and things. So, and calcifications. So how will this drug be able to help with that? And is there kind of a reversal on it, or is it just stabilized where it's at and it doesn't get any worse?
Yes, that's a key question. The basis of all that is that the population, as you know, of hypopara patient is mostly composed of female patient and postmenopausal female patient. And what is also always important to say is that once you get a treatment, and hopefully you will get a treatment for your disease in the coming years, it's going to be a treatment for life. Okay. So you have to take care about the effect, the long-term effect of the drug you are going to take on what we call the target organs. It's not only serum calcium, as you know, it's bone and kidney. And obviously, postmenopausal women have, beyond the hypoparathyroidism disease, this tendency to have a progressive fragilization of the bone due to osteopenia and osteoporosis, okay? And any drug you are administering for your disease that have a side effect or an effect on bone is to be taken into account. And you know that some of the drug in development for hypoparathyroidism have what we call resorptive effect on the bone that are strongly, some of them, which is not the case for our drug, strongly activating the bone turnover, which in the long term may be harmful for the bone. The advantage of our drug is that it has very limited effect on the bone, which is very good in terms of safety. If you imagine that you will administer the drug for many years consecutively in a female patient that are at risk of developing osteopenia or osteoporosis. And this is basically what you want to know. And for the kidney aspect of the drug, obviously, everybody, and including hypopara patient, with some of you having what we call hypercalciuria, which means that you excrete too much calcium in urine, that might help developing what we call nephrocalcinosis or nephrolithiasis that might end up in chronic kidney disease. So you want a drug that is hopefully reducing urinary excretion of calcium, therefore preventing the development of chronic disease. And in fact, as we have seen before in the phase 2 study, our drug is having strong effect to prevent hypercalciuria. So basically, the idea is to not be harmful on the bone and to be protective on the kidney side. So in terms of choice for physicians and for you patients, I think this is two very important aspects to take into consideration when you will have to choose among drugs that will be proposed to you in the future for treatment of this disease.
Yeah, that's a good point. All right. And then let's see, when will the folks who are starting optimization phase begin the trial?
It depends
Well,
on the, yeah, go ahead.
No, please, Gael, go.
It will depend how they are in their serum calcium value at the moment. You know, if they are screened and they are already in the normal range, I mean, this range of 7.8 to 9 milligram per deciliter, they may start within 2-3 weeks. But if they are not yet in this range, they will need to be optimized. Their conventional therapy will be adjusted so that they reach this target range, and this can take up to 8 weeks.
Okay.
We don't believe it can take more, but yeah.
Okay. Then will we be informed about how they are doing if we are in the trial too, or are we watching from the sidelines? So I guess, will there be updates, or will there be like a little group, or?
So there will be a committee of doctors that are going to look at the result, and in particular the safety result of the study from an independent point of view. So they are not part of the sponsor. You know, they are independent doctors that look at the data, and if there would be any issue with safety, then patients would be, involved in the study would be informed by their doctor. Otherwise, about the efficacy of the drug, if that's what the patient wants to know, no, because no one is going to know until we analyze the data and you know, that's, so it will not be informed. But if there is any issue during the study, of course, patients participating in the study will be informed.
Okay, very good. Okay, and then there's a question in there. When would somebody really know if this is going to improve their health? Would they know if let's say they got the drug, would they know within a week or 2 weeks, or what? Do you have the answer to that?
Well, it's a question. It's a difficult question. It depends what you mean by improving the disease. Obviously, for a patient, I suspect that improving the disease is improving symptoms and quality of life. Based on what we know from the phase 2 study we have performed, it's pretty quick. Mm-hmm. That is, within a few days or a few weeks, investigators and patients tell that or feel, if this is the case, that they are improved in terms of all the symptoms they can have, with the limitation that measurement of the efficacy on symptoms is something which is not easy, and this brings us to the question of what we call patient reporting outcomes, that the patient that will be part of that study will have to fill questionnaires. And I must recall that this is very, very, very important for the evaluation of the drug. And I know that this is, if I can say so, boring. This is not easy. This is questionnaire. This is, but at the end of the day, this is a very important way to assess the efficacy of the drug, and the FDA is taking very much attention to that. So please, I would advocate the patient to make efforts to fill in these questionnaires as much as possible. So just to answer your question, they will realize quite rapidly whether they have some efficacy of the drug, with the limitation that some patients may need more drug than the starting dose. So, we have a starting dose, which in this case is 20 micrograms per day. So I've seen in the past that some patients are well with this dose already and for the whole study duration, but some may need more than that. So there is what we call the titration, the increase in the dose. It may take several weeks for one patient. For example, if you start at 20 and this patient for some reason need 80 to be okay, well, it takes a few weeks or even a couple of months before the patient feels well. So that's part of the game. It's unpredictable, but be patient.
Okay. Well, currently our lives can tend to be unpredictable with this hypoparathyroidism. So right. It'll be nice to eventually get some stabilization there. So, all right. Well, very good. So if a patient wanted to sign up today, what do they do?
So the best is to look at which sites are open for recruitment. So as of today, 28th of June, it's only the first 2, but again, there will be more coming. And I don't know if this person that is asking the question is a patient of one of these sites, but the best is to talk to your doctor and say you want to participate in such a study and discuss with them. I think they will explain everything. And on this website I mentioned earlier, you will be able to see the clinic locations as soon as they are open for recruitment. So you can also go to this website on an ongoing basis to check as well.
Yeah, and there's a little bit of info on clinicaltrials.gov too that
yes.
people can go and look at as well. So thank you so much for everything that you've done over the last couple of years, getting this all together and ready for us. And to the community, thank you guys so much for attending our month-long of webinars, and I hope that it was really informative for you, and excited to see where we land in this clinical trial. So thank you so much, everybody. Have a great day.
Thank you very much.
Thank you.